Hello, everyone. Welcome to our webinar, which is Therapeutic Plasma Exchange for the Management of Autoimmune Disorders. My name is Samira, and I'm a patient living with a rare neuroimmune condition called neuromyelitis optica spectrum disorder, also known as NMOSD. I'm also the founder and executive director of the Samira Foundation. We're very thrilled to have you all joining us today for an educational program specifically about therapeutic plasma exchange, also known as PLEX, also known as plasmapheresis. As a patient who has received plasma exchange twice in my history of 10 years of living with NMOSD, I can say that it was almost life-saving for me, and in many ways it was vision saving for me. It really saved me from potential worse harm that the relapse from my condition could have posed. So I'm personally very, very grateful to Plasma Exchange and incredibly grateful to the experts that we have here today joining us to educate you all about therapeutic plasma exchange. But before we get started, I just wanted to thank Terumo BCT for their support and helping us bring this program to life. This webinar is being recorded and it will be available for replay on the Samira Foundation's YouTube channel. Please do not feel shy, ask questions. There is no such thing as a dumb question. Our experts are here for you to answer whatever questions you may have. So utilize the chat function or the Q&A functions to populate your questions, and we'll get to as many as possible. So our first speaker is Dr. Marcelo Matiello, who is at Mass General Hospital, and he will be providing an overview of neuroimmune conditions. Over to you, Marcelo.
Well, thank you, Samira, and thanks everyone for joining. I know it's a busy time of the year and everybody's planning the holidays, but as you mentioned, it's great to have this program recorded and available. As you mentioned, I am a neurologist. I'm here in Boston, and I dedicate my professional career to the understanding of the immune mechanisms, or why the immune system causes conditions such as neuromyelitis optica, MOG-associated disease, multiple sclerosis, autoimmune encephalitis. And throughout my career, I've been a big fan of plasmapheresis or plasma exchange. And that's because it does, as you mentioned, play a key role in treating attacks of these conditions. So just as an understanding, as we manage, as we diagnose and treat people living with an autoimmune condition, we always divide a concept in how we treat those problems into two different buckets, two different categories: treating the relapses or the attacks, the acute worsenings, and a second bucket, a second group of strategies and plans to prevent new attacks. In the group of treating attacks or putting the fire out, the two main options, and again, some of the people alive here, they know this very well. One of the options is high-dose corticosteroids. That's a medication that allows the immune system to be quickly deactivated, or the inflammation to be treated right away. And a second good option is plasmapheresis. And today I'm going to show you a few slides on how it works. Our second professor today here will enlighten us even more of the technical aspects of how to accomplish successfully plasmapheresis, and her vast experience in treating patients with this treatment. But I will show you a few key concepts that will potentially guide some of the the discussion and the questions. So in a second, I'll share my slides here. And I'm calling this example the therapeutic plasma exchange or plasmapheresis for NMO, neuromyelitis optica spectrum disorders. But as you see, some of the concepts here apply for any condition of the nervous system, of the brain, of the spinal cord, that is primarily mediated by antibodies. And we'll talk a little bit more about this as well. So the term apheresis or plasmapheresis, it comes from the Greek to remove forcibly. So folks in different companies, in different laboratories, Terumo, as supporting this program, is a large company that does this. There's some others and so on. They develop devices, they develop technologies to either remove the plasma, the plasma removal, but there's also opportunities in different conditions and different indications to remove and replace the red cells, the platelets, the white blood cells, even stem cells. This is a device. I think the second part of this webinar, you're going to learn a ton about how it looks, how it works. But this is the machine that helps centrifugate the blood. So the blood comes into this chamber, and by rotating really fast and by having a lot of technology, it will separate. So as the blood comes in, it will rotate. This is the whole blood, and within an hour, a couple hours, it's very, very successfully separates the red blood cells, what makes the blood red, right? What carries oxygen, the white blood cells, and the plasma. And by doing so, it removes in the plasma by specific gravity. So all the circulating, all the substances in the blood that are leading to the disease attack. So the antibodies, the cytokines, the chemokines, even if we don't quite understand well what are all the actors playing a role in causing the neurologic problem, we do know that they will be removed by plasmapheresis. Here is a little more of the technology that understands what is what and remove the plasma to be substituted for different fluids. We're going to learn more about this as well. And here, very quickly, the same idea that the whole blood comes in, it gets separated by the movement of the centrifuge. The plasma, which contains the disease substances, gets removed in a bag, and that is replaced most often with a solution of saline and albumin, is a protein that helps reconstitute, and the entire blood goes back to the patient. This is a well-established procedure, has been around for decades, has been very much studied in details on how the safety and efficacy in different diseases. And again, this is a good sentence because it says it eliminates pathognomonic or disease-causing inflammation mediator, including antibodies, complement, and cytokines. So for instance, this is a true case, a 31-year-old woman presented with severe blurred vision. And here is in the emergency room in our hospital, presenting with pain on the left eye, a lot of difficulty making sense of shapes and colors. And just as a graphic representation of what it looks like, right? And so when the optic nerve is inflamed, in the exam, 20/400, meaning, there's a lot of difficulty seeing the center of the vision. The right eye is normal. Difficulties with colors in that eye. So instead of seeing number 74, it was very, the shades or the colors are fading out. And then something that we do often is to check for pupillary reflex. So when the optic nerve is inflamed, that doesn't work as fast. So again, we knew that there was something going on in the optic nerve. So why do we choose plasmapheresis, either as a first line or as a second line when steroids do not work? That's primarily based on a very well done study back in 1999. So number of decades ago, and by Dr. Weinschenker and his colleagues in Mayo Clinic, that showed that by doing plasmapheresis, many of the patients who are not doing well, these are very severe inflammation of the nervous system, many of them end up having success, and this is after it got steroids, after a month out with symptoms. And while patients that did not have the plasmapheresis, they had a placebo, they did not do well. And that has been shown throughout many colleagues, many different types of conditions, including MS, transverse myelitis, NMO, ADEM, and even recent MOGAD. Right? There's a very recent study showing efficacy, showing that there is a key role of plasmapheresis in that disease. But as you see here, percentage of response is quite high. Again, these patients are coming to the hospital with very severe refractory presentations. A couple of years ago, we did a study here at Mass General and Brigham and Women's looking at patients presenting similar to this patient I briefly showed you, with severe inflammation of the optic nerve. Someone getting to the hospital, either one or two eyes, with a lot of blurriness, a lot of darkness. And we compared the patients who received only steroids with the ones who received steroids followed by plasmapheresis. And what we found is that the patients, if they responded to the steroids, perfect. If their vision came back within 3-4 days, you're seeing the shapes, they're reading the small letters we show, they're seeing the colors, that's terrific. But for the folks who did not improve, the ones that had plasmapheresis had a very good improvement. And this is a different scale, but here minus shows that they're improving their ability to see. So we saw that when plasma exchange or plasmapheresis was added to steroids, 68% improved completely, or a very good, partial but very good improvement, showing that in this population, these people who comes in with a first episode of optic neuritis, even though they may be due to MS or NMO or MOGAD, we're not even sure yet because the testing is being done. Using plasmapheresis as a rescue, as a second line therapy, very fast, right after the steroids did not work, resulting in very good improvement. And again, we use this findings to recommend plasmapheresis in every patient with severe optic neuritis, no matter what was the background condition, but the ones that did not respond to 3 to 5 days of steroids. As Sumaira mentioned, I wanted to talk a little bit about the mechanism, why a condition such as neuromyelitis optica, and again, this example serves to MOG-related condition. It serves to autoimmune encephalitis mediated by antibodies. Even in disease of the peripheral nervous system, myasthenia gravis, Guillain-Barré, CIDP. So these are known conditions mediated by antibodies. Antibodies are small molecules. They're produced by B cells. And here, you see sometimes people will develop this red here called NMO IgG. Red is just a representation, it doesn't look red. but this is an antibody that crosses from the blood into the brain and targets a water channel, is a protein called aquaporin 4. And by doing so, it activates inflammation, the complement inflammatory cells. And this inflammation lives in our body to protect us from bacteria, virus, parasites, allergens, and so on. Instead of doing so, by this erroneous or this mistake, this overreactive immune system, it ends up causing damage to the nervous system. So one would say, well, how do we treat this, right? One would say, well, can we find the reason why people develop this? Yes, a lot of times this is the focus of research, but it's complex because we looked into genes and triggers, and it's very hard to understand why some people develop these antibodies. So really the two main strategies, you just say, well, let's either remove the antibodies or interfere with the production or with the cascade. So a lot of the options that we have to treat lowers the production of the antibodies or blocks the complement activation or even the interactions between the cells. In the case of plasmapheresis, it's easy to understand that if these are the main drivers of the condition, by coming here and removing and putting in a bag and giving new proteins and so on, that's the disease improves quite a bit. And people have shown this over and over. There's a few examples on. So here is a study of 96 patients with NMO, 67 with steroids only, 29 with plasmapheresis on top of steroids. And as you see here, everybody with the steroids and plasmapheresis, the red, had a lot. This is worsening. This is improvement. So again, in all different levels of disability, people with the plasmapheresis did better. And different studies showing that in patients with optic inflammation, just the same as we showed in our study, patients with the plasma exchange group had more likely normal vision after the treatment, 75% against 39% of the steroids only group. And this is a very, very interesting study. The colleagues from Korea, they measure every day the levels of antibodies. So in the patients presented with an attack of NMO, but again, it could be MOG, or it could be autoimmune encephalitis, myasthenia gravis, and so on. But what they showed is that even with the steroids, the rate of removal was small, right? As the graph goes, is how much decrease or how much removal of the levels of antibodies. And you see here, some people had, maybe 30%, but some people even had worsening, more antibodies after the steroids. But here is 1, 2, 3, 4, 5, 6 plasma exchanges. And you hear more about this, how this is done. But up to 85, again, some people north of 90%, some people in the 90, but in a mean decrease of aquaporin 4 and NMO antibodies to the 85%. And finally is a colleague, Dr. Michael Levy. We know him very well. We like him a lot because he dedicated his career to the study of these conditions. He's here with us at Mass General. He looked into, again, the treatment with NMO with plasmapheresis, 59 patients, 83 attacks. And he showed that with steroids alone, it was in the 16% right there, 35% in a year. But see how much better it is with a plasmapheresis that was add-on. So I'll stop showing the slides here and potentially be available for questions now or at the end of the webinar.
Dr. Matiello, that was a great presentation. Thank you so much. And maybe we'll hold all the questions for the end if that's okay.
Yes.
Wonderful. All right. Thank you very much once again. And our next speaker is, oh my God, I hope I don't say your last name wrong, Dr. Tina Ipe or Ipe?
It's I.
Ipe. Okay, so Dr. Tina Ipe, who will be presenting on therapeutic plasma exchange for the management of autoimmune disorders. I will allow her to introduce herself, but we're very happy to have you here.
Thank you so much, everyone, for having me here. It is a pleasure. I understand how deeply autoimmune disorders affect individuals. You know, having a child who has a rare autoimmune disorder has made me understand better the patient journey that many of you go through. So remember that we are really empathetic, but as an physician who has spent many, many years doing therapeutic plasma exchange or therapeutic apheresis in general, I'm deeply passionate about the usage of this treatment for various autoimmune disorders. So I am not able to, oh, there we go. There we go. Sorry, it's just moving a little bit faster, and the key wasn't working. So anyways, I do have a disclaimer to make. This presentation is being sponsored by Terumo BCT, but however, the part of this presentation that I will be focusing on is really to provide patients such as yourself a very accurate and but scientifically based information about the usage of therapeutic plasma exchange in autoimmune disorders. But please, as always, do talk to your physician about using it on yourself. Okay, I'm sorry. I'm just having a little bit difficulty like moving the slides, but anyway, if I go forward and have to go back, please excuse it. So let's talk about autoimmune diseases in general. Dr. Matiello did such an amazing job walking us through the use of TPE clinically in patient, but I just wanted to take a step back. Autoimmune disorders, if many of you may realize, actually affects a relatively small number of individuals in the Western Hemisphere. It's about 5% of the population in Western countries actually develop autoimmune disorders. Now, the difficult part about autoimmune diseases is that it is a poorly understood group of diseases. So, what do I mean by that? Well, they're poorly understood because really, a lot of individuals, including myself, we struggle to characterize it. Is it really systemic in the sense of, someone that has systemic lupus erythematosus that affects a lot of organs, or is it localized? What is the true definition of an autoimmune disease? And I would like to say that it is a mixture of both. Individuals can have very systemic diseases, as in SLE, but also very localized diseases when it comes to things like diabetes mellitus. Now, again, we characterize it primarily because it can be a two-hit disorder. There can be a genetic component that adds to the environmental hit that a person gets to actually develop autoimmune disease. Because many of you know that just because you have a genetic mutation doesn't always mean that you will end up getting the disease. But our focus primarily is about very specific immune cells, especially the B cells, and why they go from just functioning normally to actually functioning abnormally. So if you take a look over here, what happens in a traditional system is that when a person gets exposed to a foreign receptor, which we're calling an antigen, the B cell gets stimulated and the B cell becomes plasma cells and then go on to develop antibodies. Now, in a normal functioning person, what will happen is that these antibodies will bind to any foreign substance like bacteria or viruses, and it basically tags them. And once these bacteria or viruses are tagged, what the body does is an amazing job of using things like phagocyte or other immune cells in the body to remove it out of, from causing disease. But in the case of autoimmunity, and auto is a two words, right? It's basically auto meaning to yourself, and immunity, where it's a reaction of the immune cells. What happens is that the antibodies that are produced by a normally functioning person, actually starts acting abnormally. And so what happens is that it starts recognizing oneself rather than just focusing on, bacteria or viruses. They actually start focusing on receptors in our own body and starts tagging it as being abnormal. And so again, when the tagging of our own bodies occur is when autoimmune diseases occur. So now one of the fundamental issues about autoimmunity is that it can cause very difficult symptoms. It can cause things like pain, can cause fever, can cause swelling, numbness, weakness, organ dysfunction, as well as behavioral issues. Now, Dr. Matiello talked about a lot of the organ dysfunction that happens in neurologic disorders, along with things like optic neuritis, which is, inflammation of the optic nerve, including, numbness or muscle weakness. There's so many, there's a myriad of symptoms that are produced by autoimmune disorders, including ones that target neurological structures in our body. Now, what happens is that what TPE does, and before Dr. Matiello had spoken a little bit on the clinical aspect, he had started talking about TPE and how it functions. And so what TPE, or therapeutic plasma exchange, or plasmapheresis, what it does is that it really helps to focus on removing the antibodies that are being produced and helping in many ways, not only to remove antibodies, but also the various other harmful proteins. And the harmful proteins that we're focusing on is things like complement, immune complexes. There's a lot of different things. And what it does is that if we actually replace or use a replacement fluid like plasma, in certain diseases, the plasma has enzymes in it that benefit the patient. So it is not only just removing things from the body, but it can also potentially replace the plasma that has the antibodies with good plasma that has beneficial aspects to it. But we'll talk a little bit more about that because it's only used in certain disorders, and it is also used when a patient has clotting factor problems. But basically what it does is that all in all, by removing the antibodies, we're really focusing on alleviating the symptoms in patients. So again, we'll just focusing a little bit because the word therapeutic apheresis encompasses a lot of different treatment modalities that are available to patients. But again, what the word apheresis means, which is it means to actually forcibly remove from the blood or forcibly remove something away from the blood. And it does it through this machine that you can see in this picture. And also, if you can see, I have that machine right behind me. So what it does is that this medical device takes a patient's blood, which enters into this machine, and you can see that there's a centrifuge right in this area. And what it does is that it causes the separation of the different components in blood. Many of you know that blood is composed of red cells, it's composed of plasma, it's composed of platelets, it's composed of white cells. And so what it does is that using the property of specific density, it causes the separation of these blood components to occur. And when this separation occurs, you can do certain things. So, for example, in the case of therapeutic plasma exchange, we're really focusing on the removal of plasma, which you can see is a yellow liquid substance that is being removed into this wastebasket over here. But also what you can see is there's a bottle that is being hung right in that in the general vicinity, and that is the replacement for the liquid portion that we are removing. So if we remove a liquid portion of the blood, we are also going to replace it with another liquid component. And the liquid component can be 5% albumin, or it can also be plasma that we had talked about that has really good aspects to it in certain medical conditions. Now, the other thing is, we can talk about cytophoresis, which is the removal of certain cellular component like red cells or platelets, but we're not going to focus on it. But one of the things that I want to really highlight is that therapeutic plasma exchange procedures are done frequently in the US, and about 125 TPEs are done here in the US daily. And we're hoping that that number increases, not only by the awareness by patients such as yourself and requesting your physicians to do these procedures. So I had talked about a little bit what I'm going to be showing in the slide previously. So the reason why patients would need therapeutic plasma exchange is because, again, there are harmful substances or proteins or antibodies that are mediating disease symptoms. That is a reason why we do a therapeutic plasma exchange. And what happens is, again, we take that medical device and we just remove a certain part. So if you have sickle cell disease, guess what? We're going to be focusing right in this red cell layer and removing the sickle cells out and then giving you donor red cells, which don't have sickle cell trait or disease present in it. Now, the other thing is that when we talk about therapeutic plasma exchange, we focus just on this yellow liquid, also known as liquid gold, that has a lot of nutritive properties in it. Not only does it have antibodies present in it, but it also has albumin, which is the largest protein concentration in your body and helps to maintain the viscosity or the tension in your blood vessels. Now, what this procedure does is that over time, it helps to remove the antibodies and from your bloodstream. And by removing the antibodies, again, we're just focusing on decreasing the symptoms. You can usually, depending on your height, your weight, your hematocrit, it can take about 1 to 4 hours to complete. A person who is, about 500 pounds, relatively tall gentleman will take about 4 hours. If they have good peripheral access or a central line to perform this procedure. Now, in general, TPE is really well tolerated by patients. The instrument is just so technologically advanced and has so many different sensors that it helps to ensure that the patient's safety is paramount during the procedure. Okay. So as a patient, you must be wondering, okay, this seems like a really serious procedure. How difficult is it not only to undergo it, but also what should I expect before undergoing this procedure? Now you can see a schematic here. We had talked about it a little bit, and I will not focus so much on the schematic as much as the next slide. And the next slide will show you a video that walks you through it. But what I'm going to focus on is right here. So usually, depending on where the procedure is done, you can have it done in multiple ways. You can have a needle just placed into your antecubital area, or this little this little area on your arm. And what it does is that you will put the needle, a relatively sized, a 17 gauge or 18 gauge needle into the antecubital area, and it will cause blood to start going into the machine. So of course, one of the things before the procedure that the clinic has to focus on is that if we're going to do you through a peripheral venous access, which means through one of your blood vessels, your veins, we have to ensure that your blood vessels are able to handle the machine being able to pull the blood from your body. So, we have tips and tricks to make sure that, we can do an adequate vein assessment on you and to ensure that you will be able to tolerate that one, about 3-hour procedure that most patients have to undergo. Now, in addition to the ability of your veins to handle the blood going into the machine, we also want to make sure, that the medications that you're taking, because if you're taking a medication that is only one time, we don't want you to be taking it before the procedure. We want you to wait until after the procedure to take it. Now, because again, many drugs are present in plasma. And so if you eat the medication before the procedure, guess what? That um, that uh, that medication will be lost. So, we walk you through the appropriate timing of taking your medications. We want to make sure that, you don't have any heart conditions or anything that won't make you tolerate being on the machine. So we're very, very careful about all of the symptoms and everything before placing you on a machine. Now you can see that once you are placed on the machine, there is the centrifuge, and the centrifuge will remove, whichever component that we're interested in. In therapeutic plasma exchange, we're really interested in removing the plasma. And so it gets removed as waste, and then everything else is returned back to you. Your red cells, your platelets, your white cells, or your immune cells, they're all returned back to you. And now this whole system is actually considered a closed circuit, which means that from the tubing that goes from your arm, from the needle to the tubing that is connected to the machine, it is all like there's no possibility of contamination. So, there is a very rigorous process to produce the kit used during this treatment. Okay, so Dr. Matiello had talked about this, in the US, or the use of there are two ways that you can do therapeutic plasma exchange, but the one that produces the most effective results is actually using centrifugal TPE, because membranous TPE works on a different pathway, and it is not as when you do a comparison of the two ways to do therapeutic plasma exchange, centrifugal is a much better way to do it. And the way it does it, it's that it removes the blood component either through specific gravity, because each blood component has a specific gravity associated with it. And you can see that right here. You can see that plasma has a specific gravity of 1.027 versus red cells and things like that. So each of them, based on their specific gravity, this very intuitive centrifuge that is present in this machine actually causes the separation out. And then you can see that each of the different components come out. We do take the plasma into the waste bag. Everything else is returned back to you. The good thing about this is that it is a continuous flow centrifugation. So that means that as blood is entering into the machine, blood is also returning back to you. So there's never a deficit in how much blood, is leaving your body and returning to your body. So it is always an equal balance. So let's talk about how TPE works, and I'm going to play this video for you. Can you all hear it? Or maybe I should be doing the talking. Okay, so what happens is that blood leaves the machine, it gets mixed with an anticoagulant. And the reason we use an anticoagulant is so that your blood doesn't clot while it's outside your body. And you can see that the centrifuge spins and then separates out the different components based on the specific gravity, and you can see that plasma is the lightest, and so based on this the specific gravity of plasma, it gets actually removed into the waste bag, and you can see that everything else starts to come back to you, including a replacement fluid. In this case, we can either use albumin or we can use plasma. But in most cases, we don't tend to use plasma because it has infectious disease capabilities. And so unless you have a clotting factor disorder, or, we have done, a series of TPEs every day, we don't tend to use plasma unless it's needed. So now, taking what was mentioned to you, this is what the mechanism of action is. You can see that what therapeutic plasma exchange does is that it helps retrain the immune system. So we're not only just removing the antibodies like we had mentioned, but we're kind of causing a retraining of the immune system. So what does that mean? So in autoimmune disorders, usually the T helper 2 cells are predominant. I know it's really, I mean, I have to say that immunology is even complex for a physician such as myself. So please bear with me. Basically, in a nutshell, what I'm trying to say is that it tries to remove that autoimmune balance to one that is actually more beneficial to the patient by causing a retraining of the immune system, and also really removing a lot of different things along with antibodies. We remove immune complexes, as I had mentioned, we remove cytokines, and there's also this retraining where we cause certain proliferations of the B cell. But in addition, if we are using plasma, I had mentioned that we also do replace certain enzymes back into a person who really needs it. And that is in the case of a patient that, has an autoimmune disorder called TTP, a thrombotic thrombocytopenic purpura. So let's talk about plasma volume removal. So the best way to do plasma volume is to actually do it between 1 to 1.0. And the reason why is that if we tend to do less than 1.0 plasma volume exchange, you don't remove enough of the disease mediators and cause that retraining that then will result in a poor therapeutic effect in the patient. But then when we actually do what is considered more of the standard of care, I usually advocate for about a 1.2 plasma volume exchange. It is where that sweet spot of actually removing the disease mediators to a significant degree where it decreases the symptom of the patient. It is not only therapeutically effective, but it also ensures that, the patient is getting the maximal benefit. Now, if we go any more than 1.5, you can see that the antibodies that are removed is really, I mean, the disease mediators that are removed is so marginally, like it's so marginally tiny, and it's not very different. That is why we like the sweet spot to be between 1 and 1.5, because you can see that roughly about 75% of the disease mediators end up getting removed with a 1 to 1.5 plasma volume exchange. Now, let's just go back to a little bit about why that is. So we can actually just wanted to take a few papers that neurological disease papers that shows the removal of antibodies when when using therapeutic plasma exchange. And you can see that IgM, which is an immune globulin M, it is the largest immune globulin because it is a pentamer. What you can see is, and also the other thing is that it's present primarily in the intravascular space, which is within your blood vessels. What you can see is that you can actually decrease the concentration significantly. Again, because this IgM really it doesn't have the capacity to diffuse out as much out of your blood, out of your blood vessel. And that is why you see such a significant difference in IgM mediated neurological disorders. But most of you know that most neurological disorders are mediated by IgG. And you can see that even in that situation, it does remove very quickly, but you can see that it also comes back a little bit more than IgM does. IgM doesn't seem to come back as much. And the reason being is that IgG is smaller than IgM, can actually be present in tissue spaces. And so when therapeutic plasma exchange removes the IgG from the bloodstream, what occurs is that there's a rebound effect. A little bit of the antibodies comes out of the tissues and then comes back into the blood vessels, which then again, we go back and remove. Then you can see that's a similar picture that you see in patients that have IgA mediated disorders. You can see that there is removal and then there is an uptick of those immune globulin really back into the bloodstream. And that is a rationale for why we want to do at least more than one in a patient that is very symptomatic. Now, the other paper that I really want to highlight, and it is one of my favorite papers, partly because we had worked so hard on this, but it is actually one of the largest papers on neuromyelitis optica spectrum disorder that was published by the American Society for Apheresis. So I am the chair of the ASFA Neurological Diseases Subcommittee, and we really wanted to take a look at impact of the number of TPE and the clinical status of patients. And you can see that when we take a look at the expanded disability status scale, that is a measure of various neurological functions in patients, you can see that adults who were treated with 2, 4, 6, 8, 10 PPE procedures had significantly better clinical status improvement. Similarly, pediatrics or children did really well, but there was a slight decrease, and that the slight decrease I would like to attribute to the fact that we didn't have as many children that were able to tolerate 6 procedures or more. But you can see that regardless, the more number of TPEs that are done in the acute in an acute setting, the better clinical symptomology improvement is seen in patient. And again, I would advocate for a 1.0 to 1.2 plasma volume exchange as the standard of care. Now, again, we had talked about this, and you can see that depending on the molecular weight, you have significantly different removal rates from the blood vessel. But all in all to say is that therapeutic plasma exchange does a really good job of removing proteins such as antibodies, immune complexes to help benefit the patient. Now, there are various ways that you can actually go ahead and prepare for the procedure. We had talked about this in the previous slide, but you should always let your physician know about the medication that you're taking such that they can tell you when to take the medication in context to your TPE. You also want to know how to take care of, your veins in your arm prior to the procedure. Please, 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 if you are trying to get it done through peripheral access, do drink plenty of water, the night before, at least a day before. Make sure that you have lots of food rich in calcium. We do want you to be comfortable because it's a relatively long procedure that you have to tolerate. So, be as comfortable, wear as comfortable clothing as possible. Most of the places, will have TV and, reading materials. But if you are a person that works, you can also bring your work materials for you to do, when you're getting the treatment. Do, bring all of the other stuff, the insurance information, your photo ID, when you are at the clinic, you will get your weight, your blood pressure, your temperature, all of that measured. Again, this is a clinical procedure, so we want you to be as safe during the procedure as possible. And then we will make sure that you are as comfortable during the procedure as we can make you. Okay? All right. We talked about this again briefly. There are, the one way that I really advocate for TPE in patients is through peripheral venous access. But if the institution does not have the capability of doing it through peripheral venous access, there's also that central venous access, where it gets placed right into your chest and it goes into, a major vessel of your heart to make sure that you there are ways to do it. I mean, just you have to just make sure that it is like there are no infectious risks, or you don't develop a fever or anything like that after your central venous catheter is placed. But there are also other types. There are grafts, there are fistulas, there are ports. All of these can be done. But again, we really do advocate for peripheral venous access. And peripheral venous access can be done, if you're a difficult stick, can actually be done through an ultrasound guided method. Okay, so let's talk about adverse events. We talked about all the good part. As you can see that, as the technology has improved over the years, the number of adverse events that have occurred, has been decreasing slowly. Again, this is a very smart machine, and it sends a lot of alerts letting you know, hey, the patient's not tolerating it. The blood, the blood vessel is not handling the draws, and it keeps alerting the person who's doing the procedure to either slow down or change the rate, and gives you a lot of ensures that you are taken care of during the procedure. Now what you can see is, for the most part, there were mild and moderate. And mild and moderate basically means that you have a decrease in your calcium, and so you will feel tingling around your lips and tingling in the tips of your fingers. Moderate usually means that you have some issue with the alarms going off in terms of your blood vessel not being, the machine not being able to draw as quickly as possible. So those are the things. And you can see that very, very few patients actually have severe reactions. And by severe, it means that, we like infections and things like that. So we are very, very mindful of the adverse events that our patients have during this treatment. Again, we've really talked about this. We've talked about a medication or an anticoagulant called citrate. The citrate is very localized. It only it prevents you from clotting. And it doesn't do it where the citrate comes back to you. So we actually don't call it's not a systemic anticoagulant. It is just very localized, mostly in the machine. And even if you get a little bit back, it only lasts about 5 minutes before it's cleared by your system. So again, it's metabolized very quickly. Like I mentioned, your time on the machine is very short, and do wear comfortable clothing. So sorry, and that's it. Oh, and yes, that is good. And then here are the key takeaways. We kind of hammered it. You can, I'll keep it on the slide, but then you can ask us questions about it.
Thank you so much. Very, very informative. Lots of great information. I learned a few new things as well. So, why don't we jump right into some of the questions? The first question, we'll pose this to Dr. Matiello. Can you receive therapeutic plasma exchange as a preventative? I know a fellow NMO patient that does weekly TPE instead of being on a preventative.
Yes, that's a great, great question. Thanks again for Dr. Ipe for so many amazing, amazing information. There are a couple of studies actually that looked into this. One was done in Wisconsin, and one was done through the Mayo Clinic, and both of them looked on preventive. So again, whether it's every week or it's every month or it's every 2 months, it's hard to know, but patients did well. Of course, is a trade-off, right? So it's a trade-off between taking a medicine and some side effects, or doing the plasma freezes with the. But indeed, if patients did not have a good success with medicines, or there are few centers around the country that will do that. A big one is in San Diego, but there, Dr. Ipe knows this well. There are strategies to prevent relapses. Yes.
Yeah, and
Great.
I would also like to add that, and I didn't mention this in my slides, but what therapeutic plasma exchange does, it also, by removing the antibodies, it opens up receptors, right? So neurological disorders, what happens is that the antibodies bind to receptors, right? And when the antibodies bind to receptors, you can imagine it blocks medications from working the same way. So a preventative thing would be to actually put both therapeutic plasma exchange and the medication, in a in a sequential fashion that works well for the patient and works well to reduce the patient's symptoms, right? But when you do TPE, you remove the antibodies, allowing the medications to work more effectively. So the patient may not need as much, dose of the medication, or the high frequent, I mean, not only the high dose, but the same frequency that a person who's actually receiving plasma exchange may need. But
Okay. Another question. When I was given TPE, the steroids were given before the treatment. Was that done incorrectly?
So in other words, patient had a few days of steroids before TPE, correct?
Sounds like it. Yeah.
Yeah. So that's the most common scenario. And again, there are a lot of debates on whether it's best just to start with TPE. So here we do give a couple of days of steroids at least, because it does take some time to arrange the expert team to come in, the correct venous access. And in certain conditions, the improvement with steroids is so quick, especially in the MOGAD, that sometimes you will not need the plasma freezes. However, the opposite is also true. As fast as you can get it. So we found a balance. So again, if the patient is not improving with a couple of days of steroids, boom, that's exactly when we do the plasma freezes.
yeah, and I agree with Dr. Matiello. In most institutions, that's the easiest thing to do, right? Um, it's easier to give steroids or to give IVIG than it is to do therapeutic plasma exchange. And in all fairness, right, many institutions actually don't have access to therapeutic plasma exchange. So I do want to bring that up. I think it is the difficulty in being able to, to have a clinical team that is, technically skilled, is knowledgeable, knows how to do it. Those are all very, very important things. And those are things that patients should be asking before they get IVIG or even before they get TPE, right? Who is doing it? Because it's a completely different thing when there is a hospital that has physicians that know what they're doing than versus not, right? if you get it done by, a rolling clinic that comes, I mean, they may not know you as well. So it is really, really important to know who are the providers doing the treatment for you. But it is certainly easier in most circumstances to give IVIG or, steroids and all of that before doing TPE.
Great. Well, that's actually all the time that we have. That was a very, very comprehensive presentation with lots of great information, the both of you. Thank you so much for your time, for your expertise, and of course, your dedication to patients like all of us here on the call. If anyone ever has any other questions about plasma exchange, feel free to email the foundation at contact@sumairafoundation.org, and we will do our best to get you an answer in due time. But on that note, I'd like to thank Dr. Marcelo Matiello and Dr. Tina Eith once again for being here. Thank you, Terumo BCT, for your support. And I wish everyone a very happy, healthy, and loving holiday and Happy New Year. Thank you.
Same to you. Thank you for having us.
Bye.
Bye-bye.